Okay, so we are going to go ahead and get started. We thank everyone for attending our seminar. As a brief reminder, please mute your mics or mute your site, and we'll have a chance for Q&A from Dr. Sienkiewicz when we get the opportunity. We thank you for attending our seminar. We want to remind you that we have several more coming up, and we hope you can do that. And as you know, this is a seminar series sponsored by the Office of Practice and Research here at the Jiann-Ping College of Public Health. I am the Joseph Telfer. I'm the Associate Dean for Practice and Research, and we are extremely fortunate today to have as our guest speaker Dr. Holly Sienkiewicz, who will present on exploring COVID-19 vaccine hesitancy and access challenges in Western New York. And as you know from the flyer, Dr. Sienkiewicz is the Director of Research at Common Ground Health, which is a regional planning agency in the Finger Lakes region of New York. And prior to coming to Common Ground, she was at UNC Greensboro Center for New North Carolinians. And she, of course, brings an extensive background of service and research that really centers on promoting access and integration of newly arrived, where she focused on newly arrived immigrants and refugees. And she has a long history of promotional research. She did get her doctorate of public health from UNC Greensboro, and her master's in international relations diplomacy from Seton Hall, with a bachelor's degree in intelligence studies and Russian studies from Merhurst College, which I think several people on that line will be very interested to know. I have known Dr. Sienkiewicz, have the fortune of for a good long time. We worked together when I was at UNC Greensboro. And we've been able to keep in contact off and on. And she, a fun fact about her is that she is one of those strong believers in sharing Christmas cards about her family, which I get all the time. So I've been able to witness her growing family and lovely family at that. So, having said that, then I will turn it over to Dr. Sienkiewicz and let her run the show from this point forward. And as a reminder, we will have a little time for question and answer at the end of the presentations. So without further ado, and with great gratitude, Dr. Sienkiewicz.
Sure, thank you so much. I will be sharing my screen. All right then. And can everybody see that okay?
Yes.
Wonderful, thank you. So thank you for having me today. This is very much kind of a work in progress. It's an evolution, but we'll be talking about vaccine hesitancy in Western New York. So just to start with, Common Ground Health, we are a nonprofit. We're a regional health planning agency in the Finger Lakes region of New York, which is this region in blue. We serve 9 counties, of which 8 of them are rural. So there's a kind of a misconception that all of New York is urban, and it's not. I am located in Monroe County, which that's where Rochester, New York is located. So that is an urban center, but the rest of the region that we serve is rural. And just a brief update. So our mission, essentially what we do at Common Ground Health is bring focus to community health issues as a regional health planning agency. So we very much emphasize collaboration and partnership, data analysis, and an informed approach to decision-making, resident engagement, and solution implementation. There's we have about 45 people on staff, so we're fairly small, but we do a lot of fun and exciting work. One of the things we do is we convene. We have about 25 different interdisciplinary cross-sector tables focused on key health issues that are going on in our community. So anything from healthy kids to housing and the aging community to vaccine distribution to workforce development. So really, whatever health issues are going on in the community, we convene these cross-sector tables to bring people together and find, brainstorm solutions to that. It's not just agencies we're bringing to the table, but residents, consumers, patients as well. So trying to be very collaborative in our approach. This presentation is specifically on the COVID-19 vaccine. So we co-lead the Finger Lakes COVID-19 vaccine task force. The University of Rochester Medical Center, that is the hub in our region that is responsible for the logistics of vaccine distribution. We were brought on as kind of a trusted community partner to help with trust building efforts and to help with educational efforts throughout the region. So we are really trying to take an equitable approach to vaccine distribution, to be as transparent as we can, but then also efficient. And then our work specifically, keeping community partners focused. This number 2 is kind of really where my work comes in increasing understanding of vaccines so that residents can make informed decisions. We are very much in the mindset that it is not our job to convince anyone to take a vaccine. What we view our job is to get accurate information out to those populations. There's a lot of misinformation, as I'm sure many of you know, about the vaccine. So our job is really just to make sure that people are making informed decisions, and regardless of what decision they come to. So in January, we embarked on this process of empathy interviews. Empathy interviews come out of a human-centered design approach, and we decided we kept hearing that certain populations were hesitant to take the vaccine. And it was this blanket statement that was being thrown around, and there wasn't really a lot of detail. And we were questioning it. So first of all, are people really hesitant? What does that mean? What are the nuances of hesitancy? So early on in the process, when we were tasked with the trust building efforts for the vaccine task force, we decided that we just didn't know enough and that we needed to hear from residents in our community about their concerns. So we decided to, with the task force, there are 80 organizations involved in this, so it's a large effort. We went through this prioritization process of communities and populations that have historically been marginalized or underserved by the healthcare setting. We wanted to make sure that we were hearing from them. So there was a long list of groups that we could talk to. We plan on talking to more, but we decided to start with these 9 populations. So we are in the process of conducting interviews with Black and African American populations, Latino, those experiencing homelessness, refugees, Native Americans, older adults, individuals with intellectual and developmental disabilities or their caregivers, rural residents, and immigrants. So these are the 9 populations that the task force decided to start with. And to date, I don't even want to say to date, we have 227 interviews entered into our system. We've probably conducted close to 240 interviews at this point, and we're really hoping, I'll talk about the phases, but we're hoping to conclude phase 1 shortly. But it's important to note that this chart here does not add up to 227. There are intersectionalities, and we realize that. Obviously people can be Latino and living in a rural area and over the age of 65. So there are many intersectionalities, and this is just some of the way that we're looking at the data coming in at the interviews. So trying to make sure that we're getting a good distribution by race. The Finger Lakes region is upwards of 90 to 92% white. It is a very rural region. It is a very white region overall. So really trying to make sure that we hear from Latino populations and from African American populations as well. To date, you see zeros next to Asian American, Native American, Pacific Islander. The interview process has not officially started with the immigrant and refugee groups and the Native American groups just yet. With some of these populations, we had already extensive networks, so it was easy to just dive right in and start the process. With the Native American groups, the immigrant and refugees, we are building those networks. So we're in the process of the relationship building, and we haven't actually started the interviews yet. It'll actually be a little different because the Native American group in particular came back to us and told us that interviews didn't resonate well with them and that they wanted to take a different community-oriented approach, which I absolutely love. So the process is going to look a little bit different with that group, and that's okay. We're still collecting the same information, just in a slightly different format. So those groups with zeros, they won't be zeros for much longer. They're just on a different timeline. And then again, trying to make sure social science research, we always tend to have more women than men participating. We have not specifically reached out to any LGBTQ populations yet. That is, again, on the horizon. We just haven't yet. So we will get a little bit more diversity in some of these numbers as well. And then by age, right now we have a fairly good distribution age-wise. So deconstructing hesitancy, this first slide here, I don't envision it being much that's new. A lot of people are saying that there's concerns that development has been rushed, that there's not enough information yet. That we're not surprised by at all. Through working with our research partners, we've realized that these vaccines have been in process for 10 to 12 years, if not a little bit longer. So from our background, we realized that's not the case, but it was the perception that these were rushed. So we're not surprised that we're hearing that. And a lot of people, just not knowing the side effects yet, not having enough information. There are many people who do want to take a wait and see approach for the time being. The fear of side effects, or the potential side effects as well, have been a significant cause for concern. A lot of people have legitimate fear around getting the vaccine itself and the fact that it is so new. There are some people with certain health conditions, and they're very worried how their bodies will react. So again, just kind of, I'm running through these ones a little bit quickly because I feel like there's not a lot new here that you probably haven't heard before. Another is, good physical health, or not concerned about COVID. There's a lot of people saying that it's really just another strain of the flu. They're not worried about the flu, so they're not worried about COVID. There's a lot of people that say, I trust my body. I'm overall very healthy. If I get it, I could fight it off, and don't seem to be concerned with the fact that they might get it or that they might become very sick from it. The mistrust in the government and medical establishment, again, that's not new. This vaccine, I think, I can't speak to other vaccines because I guess I wasn't around or consciously thinking of it then, but it seems to have been more politicized than anything else. So there is a lot of mistrust, both in the speed of which it's perceived to have come about, but also some of the motivations for which it's come about. So there's a lot of people that have been talking about mistrust in the government in particular. We've heard about mistrust in the medical establishment as well, but really the government is coming up more in these lines. And then also reaction of family and friends. Again, because this vaccine has been so politicized, there are people who are hesitant to take it for that reason, but there are also people who are getting vaccinated and deciding not to disclose it to any of their friends or family. So we kind of call these like the covert vaxxers. They want it, they'll get it, but they're choosing not to talk about it, or if anyone asks, to say that they haven't gotten it for fear that it will create conflict within their families or within their close circles. So in this, and if we have time, I'd be fascinated to hear how Georgia is handling some of this as well. In New York, we have large vaccine sites. Right now, we are getting to the point where we are starting to see smaller locations offer the vaccine, but we're really just getting there within the last couple of weeks. in the beginning, you saw these large mass vaccination sites, and the size and scale and location were intimidating to many people. We're especially hearing this from some of the rural populations. There are rural communities that are very small, and a lot of people are, I don't want to say necessarily scared, but hesitant to travel into the city. Don't like traveling on busy expressways, on tight, concentrated roads. The size of these buildings is intimidating to many. But also like the locations, people are asking, well, I don't know where to park. I don't know how to navigate that part of the city. So people are very concerned with just where these sites are located. Also, travel has been a concern. There's not a lot, especially in the beginning, there were not a lot of vaccine sites available. So some significant travel involved. When I say significant travel in New York, that's, 2 to 3 hours, sometimes more. I realize many other states have much more significant travel barriers, but it's still a perceived barrier in our community. Also, these sites are operated by National Guard or FEMA, staffed by FEMA. So there is a large military presence at these sites, and that has been a deterrent and cause for hesitancy for some people to access those sites. Oh, the scheduling appointments. This has been really interesting in New York. When vaccines started to become available, there was not a phone number that you could call to schedule an appointment. This has changed. This is no longer the case. But in the beginning, it was literally just a website, and a fairly complicated website at that. So many of our rural populations do not have internet access. It's just not an option, unfortunately, for many populations. We have directors of public health in our rural counties that do not have internet at home because it is just simply not accessible. So the fact that in the beginning, you could only schedule an appointment online was extremely problematic, especially from a health equity perspective. I mentioned the website is complicated, and it is. It's a lot of questions. It's a long process. So there's a level of computer savviness, even if you have the internet, to be able to navigate these sites and schedule an appointment. There's also a level of frustration too, because it is a lengthy registration process in New York. It's not really a quick 5 minutes and you're done. New York State is also asking for insurance information, which, granted, if you don't have insurance, you can still sign up for a vaccine, but that has also been a cause for concern for some populations. Because these appointments are not easy to schedule, we've also seen this degree of fatalism where it's enough of a deterrent that people just get defeated and get defeated early on. This process has not been easy. So if anyone is potentially experiencing one barrier or several barriers, it's very easy to become defeated with this process. Now, like I said, that has changed. There are now phone numbers that you can call 24/7 to schedule an appointment. There are navigators on those lines to help with scheduling, but that was not the process early on. I have ineligibility starred here. As of yesterday, New York has just opened up to 16 and over. So as we were conducting these interviews, there were many people that were hesitant, but it's who describe themselves as hesitant or describe themselves as potentially waiting to get a vaccine. But we also realized it's really easy to be hesitant when you're not even eligible for something. New York has had very strict parameters with who is eligible for the vaccine up until yesterday. So for a long time, it was only those 75 and older. It downgraded to 65 and older, and certain categories of job classifications. So certain essential workers were on that list, and that was it for a really long time. They eventually decreased it to 55, opened it up to a few more occupations, but for a very long time, and the vast majority of while we were conducting these interviews, a lot of people just weren't eligible. So it's really easy to say, I need to wait, I need more information, when it's something you're not even eligible for. But we're finding, as eligibility has opened up, some people's minds change rather quickly. So that ineligibility is kind of an interesting caveat as we're looking at these results. So ultimately, what we're trying to do here is this work is an effort to do two things. One is to provide community education. So, there are many people who say they want to hear the information from people they trust, from people in their circle. So we are taking on this large, after the data collection, we're taking on this large education effort on talking with circles, on infiltrating kind of these groups. And we're doing that through our networks. So the education effort is one side, but also the other significant effort is trying to make vaccine sites in New York more culturally responsive. And what does that look like? So right now, we're beginning to see more local pharmacies have access to distributing vaccines. That is a really good sign. It's a really promising sign, but it's something that for the first several months was just not available. So right now we're taking the information that people provide and trying to figure out what are these scenarios where certain groups or certain populations would be more comfortable receiving a vaccine. Even when people are saying, no, I don't want it, no, I don't want it, it's not for me, many are offering these nuggets, these glimmers, where they'll offer a very specific scenario that they would actually get the vaccine. And so we're taking those nuggets, are those scenarios realistic? Are they probable? Maybe not, but we're trying to take those and make recommendations to the state as to what culturally responsive sites could look like. Right now, English language access is still very problematic in terms of scheduling. And also when you get to the sites themselves, they are there's cones, there's arrows, they're very, I feel like directive and somewhat easy to navigate if you're an English speaker. If you're not, we're not seeing the language access at the sites themselves, which is, again, still continues to be extremely problematic. But what could these sites look like? So what we're doing, again, is making recommendations. And part of that will be advocating that location matters so much in these sites. Especially with our rural populations, people either don't want to travel to the larger cities or don't feel comfortable or physically can't get there. So we're really advocating that sites move to more local communities. A lot of people trust their local pharmacists, their local doctors, their local OBs, and want to specifically receive the vaccine from them. With the implementation of Johnson & Johnson, or with that vaccine being released, that becomes a bit more probable without having the storage requirements that some of the other vaccines do. They want to feel comfortable in the place, and they want it to be convenient and close. So people have mentioned local fire departments. And if their local volunteer fire department had vaccines available, that's a spot they trust. That's a spot they would go to. Churches have come up, and now we're seeing these pop-up sites, which are helpful, but they're not the long-term solution, at churches and at community centers, where for a couple days, a day or two, they'll offer vaccines to residents or to parishioners. So those are not well coordinated at the moment. And again, that's not a long-term solution. It's kind of a Band-Aid on the issue. I got into the people. What we hear time and time again is there is resounding trust in primary care providers and in OBGYNs in particular. People really want to see it from their doctor. They want to talk to their doctor. They don't want to hear it from politicians. They don't want to hear information about the vaccine really from many other people except that PCP that they know and that they trust. We've also had people say, I want to get the vaccine from our kind of people. So specifically, that was coming from some of the African-American population. So specifically Black healthcare providers wanting to hear it hear information from them and wanting to get the vaccine from them. And then we're seeing this issue around vaccine choice. So I would be interested in hearing what perceptions are in Georgia, but we have a large Catholic community here, especially in our urban centers, and the Johnson & Johnson vaccine has been problematic in that community in particular. So specifically saying, right now there's not an option as to what vaccine people get in New York. It's, if you go to the site, you will get Pfizer or you will get Moderna. And there's really not a broad availability of Johnson & Johnson in our area just yet. So that in and of itself is has been a deterrent. Some people don't want the Johnson & Johnson because of how it was developed, whereas other populations want the ease of one shot. They want the one and done, especially some of the members of our homeless community have very much wanted that. Some of the groups that are a little bit more transient, the Johnson & Johnson makes sense. Again, with that vaccine, with some of the efficacy rates, we know the studies came out saying, it's 100% effective against morbidity and mortality, severe morbidity and mortality, but less effective in terms of you could still potentially get COVID, you just won't get as sick. So there are perceptions as well that that's the lesser of the vaccine, and that vaccine is specifically for Black and brown populations, which again is a message that we're trying to advocate that that's not the case. Then you hear many people that are, with the Pfizer and Moderna, really afraid of that second shot. They've heard that they will feel sick, that they potentially might get really sick. Many people think that COVID is inside of it, and there is genuine fear around that second shot. So Johnson & Johnson in that case could be a better option for some populations, but not for all. So these are just snippets of what we're learning. Like I said, the interviews, we're hoping to finish phase 1 by the end of next week, but we've been inundated with people wanting to talk about this. So I thought we might have maybe 150 interviews. We're already up, we'll probably be 250 for this round. So with this analysis, like I said, very much a work in progress, but right now, we are taking these 227 interviews that we have to date. It'll probably be 250 by the time we finish the first round, and really diving into them and analyzing them by population. Our next phase of this is to develop a second interview guide for each specific population that we're working with, and ask more targeted questions. So about specific scenarios where people may be comfortable testing some of the information that we've heard, representing it back to the community and seeing, did we hear this correctly? Is this something that might resonate with you? Would you feel comfortable in this situation? So kind of giving them some scenarios to react to. The phase 2 interview process will be much shorter duration. We're hoping to have all of the interview guides developed by the end of April, and then conduct phase 2 interviews in May. And then with that, we'll have our final analyses and recommendations to our local task force, but also to the state, and how to improve this process overall. What we've learned throughout this work is, yes, there is hesitance for sure. Across the board in all different populations, there are hesitance, but there are also so many access challenges that are hidden under hesitancy. It's not that populations are merely hesitant and don't want the vaccine at all. There's a need for more education. There's also a need to very much address some systematic access issues for many populations. So that's kind of our next step. That's a little earlier than I thought. So I'm happy to kind of stop sharing now and answer any questions. I'd also love to hear about what's going on in Georgia as well. So yeah, if there's any questions, happy to take them.
Okay, we are open for questions. Or comments. Well, I'll start with this. So thank you very much, enlightened on this one. As you know, our college and university sits in a very rural part of Georgia. So we serve predominantly that region. We share it with our Savannah campus, which is Savannah, I think is very similar to where you are in Rochester, where it's surrounded by rural counties. And there's efforts similar to yours that are being reached out to for speaking to diverse groups of persons. Matter of fact, one of our um, uh, partners, Healthy Savannah, just received a CDC support to supplement work they're already doing around this and doing very similar work to yours. So having said that, what could you talk a little bit about two things? First, what process did you use in pulling together the information needed or the to develop your sample to inform your sample? That was the first thing. The second is, um, can you talk a little bit about how what the request is from your community about giving them feedback on what it is you know so far, as well as how you think you might do that? So those are two questions, and it's something that we deal with all the time.
Yeah, so in terms of, we have really tried to make this a community engaged process. So we at Common Ground, we're really fortunate. We have an, I don't want to say an embedded community presence, but we very much are a trusted entity with many communities, not across the board, not with all. But so because of that trust that we already had established, we were specifically asked to take on this role. So with that, part of these interviews, they have not all been conducted by our staff. Many have been conducted by our staff. We do have a very some fairly racially and ethnically diverse staff, but we've also tasked community partners. So we're community partners. They are part of our work groups. So with our rural group, for instance, there are several community organizations that specifically serve rural communities or are embedded in rural communities, and they're part of that work. And that's the same for all populations. So right now, really what we want, I'm sorry, I just got a little alert on my screen and I lost my train of thought. But what we're wanting to do is make sure that this is relevant to those we're trying to serve. So there are, we have a group called ambassadors, and they're so you might call them lay health advisors. They're not technically community health workers, but they are people who are part of these priority populations that we've identified, and they're kind of just, I don't want to say, they're liaisons to our work. So they are really kind of using some of their natural influences to help us connect with people to actually interview. This sample has not been, it's not randomized by any means. It's mostly convenience based on who we can reach. We've had flyers at public libraries, at grocery stores, kind of to help recruit for these efforts, but it's not a random sample. What we are trying to do is make sure that we address the scope of vaccine acceptance or hesitancy. So we're trying to talk to people who are very resistant. We're trying to talk to people who are very accepting, and those people in between, so that we can get the scope of the story. So I think that hopefully addresses your sampling question. And I need a reminder of what the second part was.
Dissemination, your dissemination efforts so far, plans so far. Are you all planning to do a white paper or write up or something like that?
Yeah.
As well as how you communicate it back to community. Sorry.
Yep. So right now, the main thing we're working towards right now is a report for our task force, and our regional task force has 80 community organizations involved. So that's kind of a natural means of dissemination, so to say. But really, we want to do more. We want to do white papers. We want to do some publications around this with targeted approaches, especially with some of the specific populations. we have to be realistic time-wise. I'm not sure what we'll get to. And then in terms of community members themselves, this is interesting. We're using a lot of natural networks. So we are trying to communicate the information back in forms that are digestible. We're also communicating back in forms of the education initiatives that are taking place. So this is very much informing the educational initiatives that we'll take moving forward. And that is another area where we're hoping to kind of disseminate some of this information.
Okay, thank you.
Yeah. One interesting group too is within our rural, we realize these groups are huge. Like rural is 8 counties. That's large. We realize that, but we have subsets of the population that we're specifically trying to reach out to whether it's geographically based or in our region we have a large Mennonite population, so Amish, and we're doing interviews with that group too, and that's been a really interesting process and a population that I haven't previously had access to. So it's been interesting.
Okay. Well, we do have, it looks like Dr. Fung, did you have a comment or a question?
Yes, I do. So thank you so much, Dr. Sienkiewicz, for your talk. It's really interesting. And I'm quite, I want to seek your opinions with regard to how to reach out to, for example, certain religious communities, even among the white population. So, for example, you mentioned a number of minorities groups, and you have specific outreach to African Americans and Hispanics, for example. But yesterday I read the New York Times, and they say that among white evangelicals Christians in the United States, approximately 40% or over 40% are hesitant with regard to COVID-19, and that rate is actually higher, 2 times that of Catholics. White Catholics in the US. So since you mentioned outreach to different communities, so I wonder if you have gained any insight among specific religious communities, even among the white majority populations in rural New York. Thank you.
Yes, that's a great question. And so we are fortunate that in my organization, we have a very close connection to it's called the Interdenominational Health Ministry Coalition. So this is a group of churches. They're expanding to mosques, but right now, for the most part, churches that are interested in delivering health messaging and interested in the health of their parishioners or their congregations. So they have been really vital in this effort in connecting us with specific faith communities. What we're learning from the rural populations, and we don't have a lot of evangelicals or Baptists in our area. There are some, but they're really a minority and not a large population at all. But a lot of what we are hearing is that, so with some of it, there's definitely hesitancy, but there's also the access. Access is a significant challenge in our rural populations, that people want to get it, but just don't feel comfortable given the current settings that it's being offered. But the other thing is, we really want to see, we want New York to at some point get to the point where people can choose a vaccine as well. Because like we said, we've heard some significant concerns with the J&J one from Catholics in particular. But in terms of the rural communities and the faith communities in particular, the biggest thing is that we're trying to tap into those local parishioners to help deliver messages. We're asking people about who they trust, who they would be comfortable, who they would listen to if someone were to tell them about the vaccine. And in a lot of those settings, it is the pastor. So right now we're having conversations. It actually hasn't happened yet. It's planned with some local pastors in some of the rural areas to specifically do a listening session or a focus group with them to see what are their concerns, what are their hesitancies in particular, to see if we can try to get see their hesitancies, to see if we can develop messaging for that group in particular. But a lot of our rural population has expressed that the vaccine has just been politicized too much. And that is a lot of what we're hearing from that population in particular, which I can't imagine is too different from what you may be hearing in Georgia.
Well, thank you so much. So even though there would be differences between rural New York and rural Georgia, but I also see a lot of common themes with regard to both access and also varieties of religious communities, faith communities may have similar, but actually also different in terms of concerns and how to outreach to those individuals, especially that both the leaders of the communities and also all the parishioners could be a challenge. But I certainly learn a lot from what you have just said. Thank you.
Thank you. And one interesting thing too is our approach in prioritizing the populations we talk to is based on a health equity approach. What we are quickly realizing is from an uptake approach, young rural white men are the group that we are seeing with one of the slowest rates of uptake. So we're going to be doing some targeted initiatives with that group as well, but those have not started yet. So we quickly realized we need to regroup and make sure that we're hearing from them as well.
Okay. So to answer your question that you had earlier to us, is that as Dr. Fung has said, there are really 3/4, if not 4/5 of what you've observed is similar to what we have here in our state. I mean, a little bit more on the sort of that juxtaposition between faith based, particularly with Caucasian populations, and politics, because I mean that's from your own experience of living in this part of the world, there is not always a distinction between the two, particularly around certain groups of persons, and it's politics plays a big role in both the Latino and African American population down here as well. We do not have we have a in terms of other populations like Asian, Native, those groups are not as large. They're more a smaller group here, and the LGP. I say the initials wrong all the time, but anyway, that's a group that actually we don't know as much about, and that's not great on our end. So the groups that are small that way, I mean, we have a lot to learn from those groups, and we've done that. So, like you, it's a work in progress. It's stuff we're learning. People we need to reach out to. People we need to know more about. And I'm sure my colleagues on the line could share that with you as well. Okay, other persons. Okay, all right. Well, Dr. Sienkiewicz, we are very grateful for the opportunity for you to present to us. We have already had requests for your recording from those that couldn't attend. We're competing today with a number of activities here, and our group is involved very much in public health, the Society for Public Health Education, as well as we have a pod today, a big, like one of our largest pods is going on today, among other things. So, but there have been requests for this and big interest in this. So we appreciate your willingness to share your slides with us as well as your recording. So, okay.
Yes. Thank you for having me. And again, this is also preliminary, so I'm excited to dive into it. And I'd be happy to send you an update too when we really get into the analysis a bit more than we have.
Yeah, well, that would be fantastic. And then, of course, sharing that with our own faculty, students, and with our partners who are doing similar work. It will be great when, in a couple months, when people have data that they can do comparisons with. I think we're going to find, as you know, very much a lot of commonalities, but also some distinctions, but there will be no more nuanced distinctions than they are that. And the good thing is that your findings, like findings we have from here, are just busting some of the myths about the difference between just being anti-vaccine versus hesitancy, which is what more and more we're learning, that hesitancy actually is something that we as public health persons really are behind actually attending to in the proper way, and not the stereotypes of just anti vaccine. We're finding that most people are interested in it, but like you, we're finding that people are making a distinction between the type of vaccine that there is, and for some reason or another, J&J is just not You know, it's not getting good press. And then the Cambridge one as well is a bit, but that's international. So, okay. All right. So any other comments or questions before we close our session? Okay. Well, thank you, Dr. Sienkiewicz. We appreciate your time again. And we appreciate everyone else on. Dr. Samara, did you have a comment?
No, just to thank the speaker,
Okay.
Holly. Yeah, I thought New York's not doing a good job through all your presentation. I don't know why. I think your governor has to be thrown away. So we need a new government which is more scientist. So he knows how to handle this kind of a stuff, because through your presentation, all what I hear that the difficulties, the obstacle for people to reach for those, like to get the vaccination, and also using the media to trying to talk to people, like some intervention or something, just to talk to people to convince them to take the or what they get. What do I want to trying to say? Doing commercial which is against anti-vaccination, like showing the benefits more than showing the fake news or something like this about this this vaccination. So I think there's a lot to be done. Yeah.
The state's approach has definitely been top down, which will work to an extent. And at some point, right now, demand is still outstripping supplies. There are still lines to get vaccinated, but at some point that top-down approach is going to halt, and it won't work as well. And that's where we're really advocating it. It needs to be community engaged and community informed, if not community driven. So
yeah, absolutely. We appreciate what you've done, yeah, so far. So I've encouraged you to continue and find ways. And you see, when you know what the people thinking, then you can handle it, and then you can work with it, right? So,
Right.
Yep, thank you very much.
All right. And so, as just a commentary, just to make clear that comments about politicians and governors, that is a personal statement. From Dr. Shumari, the rest of it is on that one. So, all right. Thank you, Dr. Sienkiewicz, and appreciate it. Blessing to you and your family. You're doing phenomenal work. I am extremely proud to be affiliated with you and knowing you all these years. And hopefully, we'll get a chance to invite you back at some point. So
wonderful. Thank you so much.
All right. And then one last comment from LW. That said, it was interesting to hear about the National Guard presence that will be a deterrent for immigrant populations. And that is something that, Aurelia Award. Yeah, that is something, by the way, that in our neck of the woods, we have a large military presence throughout. And so, but however, we don't deal much with as far as the immigrant population, still not real large. So thank you for that comment, Ms. Ward. So, all right. Okay. Thank you. Thanks, everyone. Have a good rest of the week. Okay.
Thank you. You too. Bye-bye.
Okay, bye.